So today we are going to talk about gestational trophoblastic disease. And let's see what we have here. So here we are having gestational trophoblastic neoplasia or gestational trophoblastic disease actually. So we have a guideline. This is how the management of gestational trophoblastic disease. And we have definitions. Now I want everyone to, the people who are going for January 2021 or July 2021, both of the exams, let me open the video also because it's a webinar, supposed to be a webinar. Okay. Yeah. So we are going to talk about gestational trophoblastic disease. Please, at any time, if you feel that my voice is not clear, so you can stop me. Athil, especially you, I want you to tell me. I want you to unmute yourself so that you can tell me if my mic is not working. Okay. Can you unmute yourself, Athil? Because I want you to speak if there is any problem. Are you able to unmute yourself? So can you unmute yourself? I unmuted you. So can you unmute yourself? Let me give the. Okay. So can you unmute yourself now, Athil? Because I want you to tell me if there is any problem in my recording. In my voice. Or Dr. Mustafa, anyone can unmute themselves. I unmuted all the participants. Athil, can you unmute yourself?
Yes.
Yeah, so I want you to tell me if there is any problem in my voice. My voice is broken, connection is bad. Anything, tell me, please.
Okay, doctor. Okay.
Okay, so let's start.
Okay.
Yeah, there is an advice for the people who is going for January and for July 2021. That either you are revising, of course, the people who are going for January exam, they are revising their guidelines, and not the first time for sure, it is the second time. And for the people who are going for July 2021, they might be reading for the first time. So whatever the case is, whenever you read any information or any topic, of course, you are going to read module wise. The modules are given in RCOG site. And anything can come from these modules. People are asking what is most important? Shall we read the last 3 or 5 years TOG articles? Shall we read the guidelines and last 3 few TOG articles? Shall we read strategy? There are many questions like this. So the answer of these questions are that you should go according to your syllabus, which are the modules given in the RCOG site. You go according to this. And how you will know that which topics are favorite of RCOG? You will know by the recalls. So I insist you to attend the recall sessions wherever there are free recall sessions and there are paid recall sessions, whatever you are attending, attend as much as possible recall sessions so that you will know what is important for them, because no one can guess and no one should guess. So you should attend as much as recalls and see by yourself what are the favorite topics. But in order to pass the exam, passing marks are not 100%. So passing marks are like, but your goal is, sometimes it is 62, sometimes 65, it is different in different exams, but your goal is to reach at least 75%. Because if you reach 75%, then attend more and more mock exams. If you reach 75%, then it means that you are safe. Now mock exams are usually made by the books, the RCOG books of different professors, but it's just a practice. These mocks are not this exactly the same that will come in the exam, but this is just to practice the speed of how you will answer your question. It is important to check your speed also, to manage your speed. So recalls, you will know the recalls because you have to do the recalls because you need to know that from where the RCOG questions are coming, and you have to do the mock exam also because you want to check and monitor your speed. Um, because there are things that even if you are very good, your knowledge is very good, still you might not be able to pass the exam, because if your speed is not good and if you don't know how the RCOG is creating EMQs and SPAs. So attending mock exams, recalls are very important, uh, together with reading the guidelines. So from where to read? So you read from the first thing are your guidelines. By when I say guidelines means RCOG guidelines. Guidelines means NICE guidelines, clinical guidelines, uh, clinical governance guidelines. Sorry, there is some sound because I am living in an area, there is Diwali, um, and and there are fireworks. Sorry for the noise. And guidelines means um, all kind of guidelines, and faculty of sexual and reproductive health guidelines, they have their own CEU guidelines, the clinical guidelines. I mean, all the guidelines, you know. And sometimes you have to go to the sometimes RCOG is giving link to the British Menopause Society guidelines, and so on. Anyway, the second thing is your TOG articles. So this is always the question: how many years you should go back? I mean, 3 years, 5 years. Usually, this is what people are saying. For me, I have no limit, and this is so no need to panic. I can go back up till 10 years or even 15 years from 2000 onward. I just want the topic. If there is a topic which is not being revised, usually the topics are being revised every few years. So if a topic is not being revised and you find it in 10 years back, I don't have any problem in going 10 years back because the topic never revised it. So this is out of question to go back 3 years or 5 years. You can even go back to 10 years if you don't find the revision of the topic few years back. It is completely fine. It means that there is nothing new, and you can rely on the information. But of course, whenever you're answering a question, you rely on your latest information. Which one is the latest? If NICE is the latest, go to the NICE. If green top is latest, go to the green top. Whatever is the latest and reliable. Now, let's start our topic. So, molar pregnancies can be subdivided into complete and partial moles based on the. Now, two things are important. The definition um, is important, and it is difficult to diagnose molar pregnancy uh, because sometimes you have to combine. Ultrasound is not so sensitive and specific, so you have to combine certain factors like hormonal beta hCG, ultrasound, and histopathological features, and then you have to go to other diagnostic features that I will discuss now. It is divided into two: complete and partial mole. Complete moles are diploid and androgenic. Once you are reading this statement, and it is from the guideline, it is very difficult to understand, but I will show you in next slide a diagram which you will never forget how it looks like. So they are saying complete moles are diploid and androgenic, okay, with no evidence of fetal tissue. So there is no fetal tissue in complete moles. Complete moles usually arise from duplication of single sperm following fertilization of an empty ovum. So you remember always this thing. A single sperm fertilizing a empty ovum. There is another variant also, which we will discuss now, but just concentrate on the first first diagram. Single sperm fertilizing an empty ovum.
Doctor, the diagram is not seen.
Okay. It means I
Yes.
have to wait for a few seconds. Maybe the internet connection is a little bit slow. Now you can see?
Yes. Yes, doctor.
Now I will go back. This is the first diagram I am talking about. Single sperm, empty ovum. And there is another variant. Two sperms, empty ovum. Let's talk about both. So mostly it's a single sperm and empty ovum. Some, as I showed you, 20 to 25% can have two sperms fertilizing an empty ovum. So now you will never forget after seeing this diagram. So partial moles, which are 90% triploid in origin with two sets of paternal haploid genes and one set of maternal genes. So partial moles occur following dispermic fertilization. It means two sperms fertilizing one ova. And 10% can be tetraploid or mosaics also. Let us see the figure, how the partial moles have two sperms and one ovum. I will wait for a few seconds for the figure to appear. Yes. So you can see two sperms fertilizing. No, sorry. This is the complete mole. It can be one sperm empty, two sperms empty, and now we are in partial mole in which uh, two sperms fertilizing an ovum. In this, you can have XXX. Sometimes it's XXY also. Let's see by the ultrasound how it looks like. I think this is a molar pregnancy. The ultrasound diagnosis, you can see the accuracy. This is from strategy, the figure from strategy. This is complete hydatiform mole. And look at the accuracy, 40 to 60% only. So sometimes I want to ask questions just to know that if you are concentrating or not, and if you are paying attention or not. So Dr. Athil, why the accuracy is 40 to 60%? I mean, what else can have picture like this?
Maybe miscarriage.
Yes,
An
that is.
embryonic pregnancy.
Yeah, they can give the same picture like this. That is why ultrasound picture is reliable in 40 to 60% of the cases. Exactly. So when I'm saying gestational trophoblastic disease, it includes hydatiform mole, invasive mole, choriocarcinoma, placental site trophoblastic tumor. It includes all. And sometimes in SBAs, they are asking about the prevalence also. So what is the prevalence? It is 1/714. You just need to remember some of the incidences and some of the prevalences. You just need to remember the figures. Okay. So how do molar pregnancies present to the clinician? What are the signs and symptoms? The classic features of molar pregnancy are irregular vaginal bleeding, hyperemesis, excessive uterine enlargement, as we all know, and early failed pregnancy. Clinicians should check urine pregnancy tests in women presenting with such symptoms. There is nothing new in it. How are molar pregnancy diagnosed? Ultrasound examination is helpful, but not so sensitive and specific in making a pre-evacuation diagnosis. But how you can do the definitive diagnosis? Definitive diagnosis is only by, this is from the guideline. The definitive diagnosis is made by histological examination of the products of conception. In complete molar pregnancy, ultrasound characteristically shows, now, how it will show? Absent gestational sac, a complex echogenic intrauterine mass with cystic spaces. Typically, in a complete molar pregnancy, the pathology shows hydropic villi. Sometimes they're asking, so it's not that when I was preparing for my exam, I was not concentrating on details like this. Then I realized when I was doing the recalls that sometimes they ask histopathological diagnosis also. So how the histopathology will show hydropic villi with trophoblastic hyperplasia. You should remember this figure. Hydropic villi with trophoblastic hyperplasia. And in partial mole, the same changes but focal. Now, how to evacuate a molar pregnancy? Suction curettage is the method of choice of evacuation for complete molar pregnancy. Before I move to the suction curettage, Dr. Atil, can you tell me, in histopathology, can you be mistaken? I mean,
No, Dr. Histopathology gives the definitive diagnosis and
yeah,
can differentiate between
I mean,
partial and complete mole.
yeah. Is there a possibility where there is hydropic villi with trophoblastic hyperplasia in missed miscarriages also?
Mm.
Is it possible? The answer is here, but I want to ask you. So this is the answer. The answer is yes, you can be mistaken, even by histopathology. The histological assessment of material obtained from medical or surgical management of all missed miscarriages or all failed pregnancies is recommended. You should do, even for missed miscarriage, you should do it because you want to exclude the trophoblastic disease. Now, ploidy status, it's diploidy, tetraploidy, or diploidy in complete mole. Usually the problem is with partial molar pregnancies. Complete mole is usually typical, and partial molar pregnancy sometimes is difficult to differentiate from the missed miscarriages. So how you will differentiate? By the ploidy status. What is the meaning of ploidy status? How you will know that this is not missed miscarriage and this is a partial molar pregnancy? Ploidy status, Dr. Athil.
Yes, partial molar pregnancy is triploid, always a
Yeah,
triploid.
yes, and then in missed miscarriages you will have diploidy and
Diploid.
immunohistochemistry staining for P55. Now this statement is important. Don't take it easy, huh? Because this is how you are differentiating complete mole from partial mole, and it is used to confirm the diagnosis of complete mole. So sometimes there might be a confusion between partial mole and complete mole, how you differentiate by the immunohistochemistry. And I remember in one of the recall, they were asking about immunohistochemistry, that it is used for what, and I think this sentence is important. Immunohistochemistry staining for P55, it is used to differentiate between partial and complete molar. and to confirm the diagnosis of complete mole also. Now, should products of now let's go back, because in guidelines sometimes they are giving not in a sequence. That's why the questions might remain in your mind and the information is not complete, but it is there at later on. So this I am correlating between here and there. So evacuation of a molar pregnancy. What is the treatment of molar pregnancy? Is evacuation. So suction curettage or suction evacuation is the method of choice of evacuation for complete molar pregnancy, except when the size of the fetal parts, of course, if you cannot just in partial molar, Dr. Atil, can partial molar pregnancy can reach to the second trimester? Is it possible?
Yes, doctor. It can
Yeah,
reach with large fetal parts.
that is true. Do you know that what are the problems that can happen if it reached to second trimester, and how the fetus looks like? Is it a normal fetus? Because the pregnancy is alive. Is it going to be a normal fetus?
Yes, yes, doctor.
Now, if you have read the TOG article, you will know that the 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 fetus will not look like normal. It is with congenital anomalies.
Mm.
Yeah, it is usually heart and I think limb abnormalities, something like this. So it is with congenital anomalies. And very interesting information I find that the baby will be IUGR, and it is a symmetrical IUGR. This is how you will know. So I know that we are talking about IUGR not in this context, but this is an information I found from a TOG article. It's not from my mind. It's not from somewhere some textbook that I'm reading extra. No, nothing from the TOG article. Okay, let's move. And if it is it reached to second trimester, then of course we can always do the medical evacuation. Now, a urine pregnancy test should be performed 3 weeks after medical management of failed pregnancy if products of conception are not sent for histological examination. So, for all pregnancies, um, for all failed pregnancies, missed miscarriages, you are doing, sometimes you are not, a patient might miscarry somewhere else. I mean, not in the hospital. And it is not possible to send the histopathology for all products of conception. So what you should do if you are not able to send the histopathology for the products of conception, you just need to perform the pregnancy test 3 weeks, even after medical management, or with a spontaneous miscarriage, whatever. After 3 weeks, you have to perform urine pregnancy test. If they're asking you, not the blood pregnancy test, not the serum pregnancy test, urine pregnancy test after 3 weeks for all miscarriages, unless you have histopathology confirming that this is not a molar pregnancy. Now, Dr. Atil, I have a question for you. NTD is required following evacuation of molar pregnancy. Is it required in partial or complete, or both?
For both, doctor. For both.
Yes. I don't know why some people are have confusion about this. I mean, there is no need for any confusion. It is written very clearly um, here. I think the confusion arises sometimes. I don't know why. Do you know why the confusion arises? I don't even know.
Doctor, in the guideline, in the discussion, they said if complete mole
Hmm.
is diagnosed by histopathology, so no need for NTD. But
Hmm.
there is delay when the histopathology, the result appears. So there is a
Oh,
delay. So
that is
there may be.
okay. Okay, that is why people are confused. But if they are asking you that should we do it or not, so the answer is yes. Should we give or not? So the answer is yes. For whatever the reason, as Dr. Atil is saying, described in the description. So we go according to the bold letters. The bold letter says it should be done, so it means that we should do it for all, partial and molar. But why the logical the logic is written in the description, but I don't want you to confuse yourself that shall we give it or not. So if the question is shall we give, the answer is yes, we should give to all, partial and complete. And whenever you are reading, you are revising yourself, just read the bold letters, because if you are able to remember the bold letters or the summary of the guidelines which is usually given, then this is more than enough. But while you are reading for your exam, anything important which you think in the description is important, just write in soft copy or hard copy in front of that bold letter, so that you don't have to go back, or just highlight it. Revision, you have to revise all of your information and all of your syllabus in 1 week. So you should create your information, and you should have your information written in a place that you will be, or in a bullet points, or highlighted material. I don't know how you are making your notes, um, but it should be everything should be revised in 1 week. It should be in a way, and this is a skill also. There are many skills that you need to learn, and this exam will teach you many skills that will help you later on in your life, not only for the exam, not only for the exam. Okay, so is it safe to prepare the cervix prior to surgical evacuation? Preparation immediately prior to the evacuation is safe. Can oxytocin infusions be used using surgical evacuation? Um, Excessive vaginal bleeding can be associated with molar, and a senior surgeon directly supervising surgical evacuation is, of course, a senior surgeon should do it. The use of oxytocin infusion prior to the completion is not recommended. Um, if the woman is but there is a but in everything. If a woman is experiencing significant hemorrhage prior to evacuation, surgical evacuation should be expedited. So what is the answer? If there is an EMQ and they are asking, there is a molar pregnancy, and the patient start to bleed heavily, and you not yet completed the evacuation, so your option and your answer should be to expedite the surgical evacuation. And then after you remove most of the tissues, you can start oxytocin infusion, because there is a risk of tumor embolization anyway. But if there is a life-threatening bleeding, uh, if the question is asking about a life-threatening bleeding, then you can say yes, oxytocin infusion may be used even before completing the evacuation, because you will deal with the tumor embolization later on, right? You just need to save the life of a woman. Should products of conception from all miscarriages, we already discussed about this. Now, Dr. Atil, I want to ask you something. So, termination of pregnancy. What is the meaning of termination of pregnancy? Why they give it separately from failed pregnancies?
It is because of therapeutic termination, for maybe because of congenital abnormality, or because of medical condition. If there is any threatening to the life of the patient, should be terminated. So it is a normal pregnancy, but for any cause, any medical cause, should be terminated.
Yeah. Is it included? Can you use the term of abortion for this kind of termination of pregnancy?
Yes, doctor. Yes.
Yeah. You can use,
Yes.
because if you go to the Abortion Act, all what you are saying is included in all the acts to save the life of a woman. If the fetus is having anomaly, everything is, I mean, is in the Abortion Act, for the mental and for the physical. If there is a threat to the life, A, B, C, D, E, you remember the Abortion Act?
Yes.
So you can say in abortion. Why they are saying that there is no need to send for histopathological examination after surgical termination of pregnancy?
Yes, only if the fetal part is seen by prior ultrasound. Only in
Yeah,
this case. If
there
there
is
is
no
no
need.
previous, even in Abortion Act, if there is no prior ultrasound shows that the fetus is viable, normally seen, so it should be sent. The product of conception should be sent for histopathology.
Yeah, logically speaking, they're saying that if you have seen that a lady who is doing an abortion according to the abortion clause C for the social reason, and you have seen the fetus by ultrasound, then there is no need to send it for histopathology. There is no need to send for histopathology because she want termination of pregnancy on an abortion clause C, and you have seen the fetus which looks normal, so they can ask an EMQ something like this, that for termination of pregnancy if it is needed or not. Yes, it is not needed if you have seen it on the prior ultrasound examination.
But doctor, if there is no ultrasound, if,
uh,
if the patient didn't do ultrasound,
I
should
want
we
to ask
send?
you. Yeah, yes, actually yes, but I want to ask, yes, we should send. The answer is yes. That there is another question related to this. So in the abortion guideline, we read abortion guideline together, isn't it? So is ultrasound is necessary before termination of pregnancy or before abortion, before the surgical termination of pregnancy?
Yes, because if we miss any molar pregnancy, there may lead to life-threatening complication, may lead to hysterectomy, to chemotherapy,
Yes,
to the need
because
for
I
chemotherapy.
think that there is written somewhere that ultrasound is not necessary, but in the guideline, in the main guideline, it is mentioned that we should do the ultrasound. Yes, so we will have ultrasound if we are going for surgical termination of pregnancy. We will have most probably ultrasound because it's not allowed. So that's why there is no need to send histopathology because you already have an ultrasound. I'm talking about if some lady want to do a termination of pregnancy and uh, it's an abortion, by definition. So, Dr. Athil, what is the indication for second evacuation?
There is no need for second evacuation, for routine second evacuation.
Yes.
But in cases that if there is some benefit from repeat evacuation, if the HCG level is less than 5,000 IU per liter.
Mm-hmm. Mm-hmm.
So in this case, some case series shows that there is a benefit for a repeat evacuation.
And there is
But
one
it
more
is not a rule.
indication. You should know the indication. Of course, it's not
Yes,
routine.
if there is still the patient complaining from irregular bleeding, if there is still complaining from symptoms.
Dr. Athil, why I'm targeting you and asking you all the questions? Don't be upset, huh?
No, of course.
Because I'm asking you because you are my course student, right?
Yes.
Okay. And I saw your name, the first one, that's why.
Review
and
this
we
too.
and we reviewed all together.
Yes.
Anyway,
Okay.
okay. So a small minority of women with disease limited to the uterus. So the second indication, if the disease is limited to the uterus. Of course, if it is already disseminated, what is the use of doing second evacuation? If there is a recurrence of the disease and it is limited to the uterus, it is inside the uterus only, you can evacuate it. And the other thing, as you said, beta HCG level. There is a cutoff value. Historically, the SCG cutoff value of under 20,000 for women with disease limited to the uterus had been used when considering further evacuation. So there is a cutoff which is given in the talk. This is a copy paste from talk article. I usually like to do copy paste. I don't make my notes, although I can do it, but I don't like to do it because sometimes there are mistakes happen when you make your own notes, and I want you to uh, Dr. Athil knows why I'm not doing why I'm not making notes, because the wordings which are written in the guideline and in the talk article, this is exactly what they want in exam, in EMQs and SBAs. And while someone is making their notes, they can omit some important information which I think that maybe it is not very important, but it is important in eyes of RCOG. And sometimes I might change something, not intentionally, unintentionally. That's why I want you to read exactly and memorize exactly what is given by the RCOG. If it is written even less than, more than, equal to, I mean, even they're asking, this is more than 20,000, this is less than, this is equal to or more than. So, I mean, these things, and no one can be so perfect like RCOG people who are making these talk articles. I don't consider up to their level, so I cannot create something like what they have created. So I don't like to make my own notes. so so you have two indications. If the disease is limited to the uterus, and there is a cutoff if it is a beta HCG is less than 20,000. Okay, let's see. They are saying rarely in some of the hospitals, for example, it depends upon the consultant, but even if it is more than 5,000, I mean, some people are doing it. If you are usually up to 5,000 you can do it, but up to 20,000, yes. But if it is more than 5,000, then usually you need the patient will need chemotherapy. This is they are giving an idea that if it is more than 5,000, patient most probably will need chemotherapy, but you can go up to 20,000. Under 20,000 you can do second evacuation. Okay, this box is very important for me. What is the indication for initiating chemotherapy following molar pregnancy? I think you need to memorize this. You see? So the question is when to, if there is a molar pregnancy, you have evacuated it, what is the indication to start chemotherapy? Okay, you find a molar pregnancy, you diagnose a molar pregnancy, you do histopathology, you are confirmed that this is molar pregnancy, partial molar pregnancy, or complete molar pregnancy. Now you decide that if you are going to do second evacuation or not on the basis of these two criteria, and most probably you will decide not to do second evacuation. But what is the criteria of starting chemotherapy? Let's see. Now, if it reached to brain, liver, GIT, or lung metastasis, and the metastasis is more than 2 centimeter on chest X-ray. Now, this is a very important piece of information. Any metastasis to lungs does not necessarily mean that you will start chemotherapy. This more than 2 centimeter is an important cutoff to start chemotherapy. So, Dr. Athil and all of you, I want you to remember that this cutoff for lungs is important, or on chest x-ray is important to start chemotherapy. But if it is in brain, yes. Any metastasis, any size in brain, yes. Any size in liver, yes. GIT, yes. But lung, more than 2 centimeter. Histological evidence of choriocarcinoma. If it's therapy, yes. Let me do a question answer form, and I can see. Oh, okay, Dr. Athil. Can you tell me, just give me yes or no answer. So
Yes.
when to start chemotherapy? Okay.
When?
So
Yes.
if there is a histological evidence of choriocarcinoma, when you're confirmed that it's choriocarcinoma, you will start chemotherapy or no?
Yes. Yes, doctor. Yes.
Yes. So the other question is, if you find that there is a uh, mm, okay, beta HCG is very high, you will give chemotherapy. But how much high you will start chemotherapy? I mean, after evacuation, and you check, you give even 4 weeks, more than after 4 weeks, you check beta HCG. Is there a cutoff?
Yes, doctor. Yes.
Hmm.
If it is more than 20,000,
Yeah. After
4 weeks
4 weeks,
after evaluation.
yes, exactly. And for example, if the beta HCG is not increasing, but it stays plateau, for how many samples you will check and then you will start chemotherapy?
If there is if there is a 3 consecutive samples with stasis,
Mm-hmm.
now we should start chemotherapy. There is no decline.
Yeah. For example, the beta HCG is say 15,000 or 10,000 after 1 week, again 14,600, and then after third week it is 15,500 or so. It's more or less like a plateau line, because in the real exam they will give you a figure. They will not say
Yes.
3 consecutive exactly what is written in the talk article. They will give you a number, and then you have to make out that this is plateauing, this is not increasing. So plateauing in after 3 consecutive serum samples, if it is plateauing, then you can start giving chemotherapy. Or after 6 months, if there is raised beta HCG, after 6 months, there is not supposed to be, mostly when it returns to normal, usually, Dr. Atil, what is it in the guideline?
Usually, we should follow up the patient.
Mm-hmm.
First, any GTD should be registered to the
Yes.
Trophoblastic Screening Center.
Okay.
Then should be followed up for HCG.
Okay.
If it is retained to normal within 56
Yes.
days,
So we should
then
remember this cutoff, 56
yes,
days. Okay. Okay.
yes, then
Yes.
then we should stop monitoring 6 months after the evacuation.
Mm-hmm. Okay. Good. And 56
Yes,
days means how many months?
2 months.
So it means that usually it comes back to normal within 56 days,
Yes.
although it is not
If it
written in the not
yeah,
written in the
if it is
guideline.
if it is not returned to normal after 56 days, then we should monitor it for 6 months from after normalization.
That is true. This is the difference.
Yeah.
And so 56 days needs to be remembered, and it is given in the guideline. So so it means that after 6 months, usually more than 90% will return to normal, right?
Yes.
But still, if you find raised beta HCG level after 6 months from evacuation, then it means that there is something going on. It is not, it is a maybe a invasive disease, it's neoplasia, and then she might need a chemotherapy. And we will see how to give chemotherapy on what basis. Okay, talking about registration, you already said that we need to register. And we all all know that the patient needs to be registered. And what are the and what are the patients that needs registration? Complete mole, partial mole, twin pregnancy with complete or partial mole. If the patient has limited macroscopic or microscopic molar change only, suggesting possible partial or early complete molar, needs to be registered. Choriocarcinoma, placental site trophoblastic tumor, we will see what's the meaning of this. And atypical placental site nodules. I saw some of the recalls asking about placental site trophoblastic tumor, asking about choriocarcinoma, asking about atypical placental site nodules. So they are asking about all these, and you should know all these terms, not only partial and complete, you should know all these terms. So atypical placental site nodules. There is a nuclear, what is the difference between why they said atypical? So it's an atypia of trophoblast. There are areas of necrosis, calcifications, and increased proliferation. And what is the immunohistochemistry that they are using? Not like before, it is Ki67. They might ask you this within a placental site nodule. So there might be just a nodule and there are atypical changes in it, and there is a proliferation. You can see it by the immunohistochemistry. Now, recent reports suggest that a proportion of atypical placental site nodules may transform into placental site trophoblastic tumors. So that's why they should be registered. Now, talking about 56 days. Is it 2 months? Exactly. Almost. Okay, it's almost 2 months. It's okay, no problem. So follow-up after gestational trophoblastic is individualized. If SCG has reverted to normal, as Dr. Athil said, within 56 days of pregnancy, then we will follow her up for 6 months from the date of evacuation. This needs to be remembered, from the date of evacuation. If it's not revert to normal within 56 days, then follow-up will be also from 6 months, but from normalization. This is the only difference. After the SCG, whenever the SCG becomes normal, from normalization, 6 months more. But if it returns to normal within 56 days, then from the evacuation, 6 months. All women should notify the screening center. Now, one more thing, whenever a woman who has this molar pregnancy, whenever they become pregnant, they have miscarriage or they are delivering normally, normal delivery by cesarean section or by vaginal delivery, whatever, they have to notify the center. And the beta HCG should be measured. I saw some of the recall asking about this. Beta HCG should be measured 6 to 8 weeks after the end of pregnancy to exclude the disease recurrence. All kind of pregnancy, normal pregnancy, miscarriages, 6 to 8 weeks. Okay. How should persisting symptoms after an evacuation be managed? The same thing. What can be the symptoms, Dr. Athil? How the patient might know that there is something wrong? So after evacuation, the bleeding usually becomes less, very mild. There is no pain. So when she should be alerted when a patient, what are the symptoms? Dr. Athil, what
Yes,
are the
doctor.
symptoms after evacuation the patient should be alerted?
The most common symptom is irregular bleeding.
Yes.
But there is a rare symptoms, maybe dyspnea or neurological symptoms, which is rare, which is
If there
due
is
to
a spread,
metastatic disease.
metastasis, yes. Patient
Yes,
might still have pain. Patient might still have bleeding, which is usual then, because after every evacuation there is some bleeding, but maybe it's more heavier. And due to metastasis, patient might still feel some symptoms. Maybe she still feel nausea, vomiting. So
yes.
then she need to notify, and beta HCG should be done. Now consultation with the okay. So, and then the specialist will decide whether to do the second evacuation. They will do the beta-CG, they will do the ultrasound, and will decide whether she is um, whether it is indicated to do the second evacuation or not. And if it is not, then there is a criteria of starting chemotherapy, and they will start chemotherapy according to that criteria. We will see what's the criteria. Now, which woman should be investigated for persistent gestational trophoblastic neoplasia after a non-molar pregnancy? Even if the pregnancy is non-molar, any woman who develops persistent vaginal bleeding after a pregnancy event is at risk of having. So you should think the patient has miscarriage, she just delivered. Usually after 4 weeks there is no bleeding, but if the patient is having persistent vaginal bleeding, then you should do, even if she has no history of molar pregnancy, any patient who deliver usually after 4 weeks, um, unless she has another period, or if she is pregnant again and she is aborting, she should not have bleeding. But just keep in mind that irregular vaginal bleeding might be due to a pregnancy, and then maybe she has that neoplasia, persistent gestational trophoblastic neoplasia after a pregnancy even. Symptoms from metastatic disease such as you said, dyspnea, abnormal neurology, dizziness. Now this is very interesting. Dr. Athil, there can be a
Yes.
twin pregnancy, a normal twin, usually in dizygotics, a normal twin with a partial
Uh,
molar or a complete molar.
yes.
If it is possible, then what you should do, if you are in doubt that the second is missed miscarriage or a partial molar, what you will do?
If we suspect there is a co-twin molar pregnancy, so should refer the patient to fetal medicine unit.
Yes. If they ask you what you do next and it is one of the option, you will take this option. But what they will do?
If there is uncertainty about if it is a molar pregnancy, they should
Hmm.
perform a prenatal invasive testing.
Yes, yes. So it can be in the form of, according to the gestational age,
Yes.
what invasive testing can be done?
Either choriocentesis or amniotic fluid sampling.
Yeah, or amniocentesis. Okay, any testing can be done according to the gestational age, but the important thing is to know, um, but the important thing is to know um, that you have to do the karyotyping, fetal karyotyping.
Yes.
Okay. Why Dr.
Or,
Daraksha is unable to? I think link is working. Prenatal invasive testing for fetal karyotype should also be considered in cases of abnormal placenta. And if you suspect any abnormal placenta, mm, Dr. Athil,
if,
is there a problem in
yes.
link? Is it working?
No, 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 doctor.
Okay. So, okay, no problem, because I cannot help in the middle. Let's see. So, prenatal invasive testing for fetal karyotype should also be considered in cases of abnormal placentas or any abnormality found in the placentas. Then karyotyping can be performed also. Now, you see, I took this one from strategy. This is how interesting, isn't it? Complete hydatiform mole, complete mole, and a normal fetus. Okay. What is the incidence? Very vast between is it rare, Dr. Athil, or it is uncommon? What is it? Very rare of rate.
Incidence?
Mhm.
No, no, I don't know.
Can anyone tell me? Can anyone else tell me? Is it rare or is it uncommon? We have other people, Dr. Athil, from our group.
Don't-
1 in 100,000. What is it?
1 in
What it looks like?
100,000. Yes, it is more than.
Mhm.
It is very rare. If it is more than 110,000, so it is very rare.
Yeah, you can say if it is 1 in 20,000 to 1 in 100,000 that it is rare. So, but we should remember, Dr. Athil, you should memorize. Even I sometimes I forget also, but you should memorize what's the meaning of, because sometimes in EMQ they're giving a figure and they want you to know that if it is rare or uncommon or common or very rare. So just memorize this. You know our guideline for what is the name of this guideline? Presenting information on risk. It's a clinical governance guideline, I believe. It is given there, the definition of all this risk. So there is a mainly theoretical concern that such pregnancies are associated with increased risk of congenital fetal abnormalities, perinatal mortality, and malignant gestational. What is the concern? What you will recommend, Dr. Athil, if a patient has a twin and one looks completely normal and the other one is complete or partial molar, there is a risk of higher perinatal mortality. She can have
Yes,
malignant gestational trophoblastic neoplasia, and the normal baby can have congenital fetal abnormalities. So what you will advise her?
yes. We should counsel the patient that if she want to continue the pregnancy, there is a risk of an increased risk of perinatal morbidity and the risk of development of gestational GTN, gestational.
Yeah, counseling. So, but will you, because
There
in
is.
the question and answer they're asking one answer, right? So if I am asking you, will you advise her termination of pregnancy?
I should counsel her and give her the risk that if the pregnancy continues, I should tell her that there is a risk of early pregnancy failure, which is there is there is a percentage that 25% may have a live birth.
There is a observational data suggests 40% of women will deliver a healthy baby, so you cannot advise her by yourself to do termination of pregnancy.
Yes,
This is the
Doctor, why
thing.
the percentage is different from the guideline? In the guideline, they say 25%.
Yeah, so you go according to the guideline. It's okay. It's a TOG article.
Yes, yes.
And whenever there is a contradiction between percentage in the guideline and in the TOG article, we go according to the guideline.
Right.
And we will see what is the latest. This molar pregnancy TOG article is, I think this is not even a TOG article. This is a strategy. It looks like strategy because I took evidence from strategy, TOG, and guideline. It looks like
Yes,
strategy.
it is.
Yeah,
Yes, it's a strategy. Yes.
yeah, yeah. No problem. You take information from your guideline. But anyway, you have to inform the woman about all these risks. And they
Yes,
can
there
do
is.
the yes.
There is a 40% risk of early pregnancy failure,
Hmm.
36% of premature delivery, and there is a risk of early preeclampsia, up to 20%.
This is exactly what I want to tell you. This is from another TOG article, very old TOG article. I will not tell you how old because otherwise you will lose your interest. But this paragraph, I find it interesting from that TOG article. Let's see. A complete heretiform mole may coexist with a normal fetus and a placenta in cases of molar transformation of one ovum in a dizygotic twin pregnancy. Mothers with this condition, concentrate from this point. Mothers with this condition are at higher risk of persistent trophoblastic tumor requiring multiple cycles of chemotherapy than patients with the classic molar pregnancy. 50 to 60% versus 10 to 15%. So more will have persistent trophoblastic neoplasias. And vaginal bleeding from the second month of pregnancy is the most common presenting symptom, as it found in 90% of the cases. The mother must be informed. Now, what you will counsel? If she wishes to continue with the pregnancy, she will be having higher risk of developing the severe medical complications, pregnancy-induced hypertension in 50 to 60. What is the percentage you said about preeclampsia? Dr. Athil?
Yes, doctor, up to 20% in the guideline.
Preeclampsia.
Yes.
But I think they are talking about pregnancy-induced hypertension. Maybe it might be a little bit more. These complications are often related to high beta HCG. In women deciding to continue with the pregnancy, serum beta HCG can be used to monitor. Now, if the patient will say, I do not want termination of pregnancy, after hearing all this, how you will follow up? Is it written in the guideline? It's a twin pregnancy. There is one molar pregnancy, partial or complete. The other one looks like normal pregnancy. You checked even the karyotype of the fetus, it's normal pregnancy. There is no congenital anomaly. The woman, she knows that she can have pregnancy induced hypertension, she can have perinatal mortality, she can have, um, preeclampsia, persistent gestational trophoblastic neoplasia, and if she has, she will require multiple chemotherapies. She knows all this, but she said, I want to continue because anyway, there's a 25% chance. It's a precious baby, and I want to continue. This is my only pregnancy. I'm 40 years old, and I'm not going to have another one. So, what you will do, how you will follow her up? Because recommendation is to do for a normal pregnancy or for a twin pregnancy, you are checking by ultrasound, right? Only. But what I find here in this talk article that they are saying that the serum beta HCG levels can be used to monitor the growth of the molar mass until fetal viability is reached. Interesting, isn't it? What is the meaning of fetal viability? Viable fetus.
And
Dr.
up to
Athil?
26 week, up to 26 week.
Yeah, viability can be reached until 24 weeks. Um, and from 22 to 24 weeks, they are at the threshold of viability. Have you read the talk article of threshold of viability, right? It's a very interesting article with a lot of information. Anyway, but maximum until 24 weeks, most of the it's a viable pregnancy. So we don't do beta HCG routinely for all patients. But if there is a molar pregnancy, then they are saying that you can monitor the growth of molar mass with the help of beta HCG. Interesting. Okay, treatment of persistent trophoblastic disease. Now, invasive moles means it will evade the
And
myometrium.
about this talk about twin pregnancy. We do not have this talk.
It's very old one. Atil, just forget about it. It's just, you will laugh at me if I will tell you the year. It is
I know you
2003.
like, yes, you like, doctor, you like all the talk.
No, but I want to, it's it's just that if I find in one topic, you cannot read from one source. If you read any topic
Yes.
from one source, it means you are not going to pass the exam. It's very difficult. I mean, by chance you can, uh, but then it will become difficult to pass part 3. Your knowledge should be complete. So you should read one topic from 2 or 3 different places. I am not recommending you to read all the talk articles that came since you are born. No, no, not at all. But at least you need to go back to see until, I mean, if there is no latest talk about this topic, you can go back. I mean, just have a broader view, have more flexibility. So invasive moles invade myometrium or venous channels. 10% of hydatiform mole progress to invasion. Now this percentage is important. Sometimes they're asking what is the percentage of hydatiform mole progress to invasive, and 15% of invaded mole goes to lungs or vagina. So invasive moles, they can invade myometrium. This is called invasive mole, and they can go to the venous channels also. And how much is the hydatiform moles progress to invasion? It is 10%. These figures are important for SPAs also. And 15% of them who are invaded, they goes to the lungs or vagina. Just remember, there's nothing to explain more. Just remember. Now, pre-treatment investigations. Patient is going for a treatment, chemotherapy, right? And before you will start the treatment, um, what are the investigations needed? After a recent molar pregnancy, the investigations performed prior to chemotherapy are limited to Doppler's ultrasound scan of the pelvis, chest X-ray. The ultrasound allows the formal exclusion of a new pregnancy as the cause of beta HCG. So what is the indication of doing an ultrasound? First of all, you want to see that maybe she has a new pregnancy, that's why beta HCG is elevating, and measurement of the size of the uterine tumor, while the chest X-ray gives an indication of pulmonary metastasis. Now there are 2 groups. There is a low risk group. It includes women scoring 0 to 6, while women scoring 7 or higher fall into the high risk treatment group. So this figure is important. Score of 0 to 6 is low risk, 7 or more is high risk. Now, low risk disease. The first cycles of treatment is given as inpatient with the following cycles uh, administered closer to home. Women with an initial pre-treatment SCG. Now, this figure is important. If the before chemotherapy, if beta SCG is more than 1,000 international unit, look at the units. In the exam, sometimes they change the unit. So this unit is international unit in the guideline, international unit per liter. So if beta SCG is more than 1,000 international unit per liter, sometimes they will give you another unit, and you should know how many units beta SCG can come in and how to convert one unit from another one, because they might give one unit which is not given in the guideline. Okay, so if the beta SCG of more than 1,000 international unit per liter, if this is the initial beta SCG, they have to stay inpatient because of the risk of bleeding, and they will shrink very rapidly. It's a very nice responding tumor. Okay, now women with gestational trophoblastic neoplasia may be treated either with single agent or multi-agent chemotherapy. Now treatment used is based on the FIGO 2000 scoring system for gestational trophoblastic neoplasia following assessment of treatment center. Need for chemotherapy following a complete mole is. Now, this percentage is important. Need for chemotherapy after a complete mole. So, Dr. Athil, what is the percentage of receiving chemotherapy after a complete mole? What is it? It is 15%. So it is 15%. The need for chemotherapy following a complete mole is 15% and 0.5% after a partial mole. The need for chemotherapy. You should remember this figure. Just remember this figure. Now, women with scores 6 or less than 6 who are low risk, they are usually treated with single agent intramuscular methotrexate alternating daily with folinic acid for 1 week followed by 6 rest days. Just need to remember it. Now, women with high risk who are high risk, score 7 or more than 7, and are treated with IV multi-agent chemotherapy, which include combinations of methotrexate, dactinomycin, etoposide, cyclophosphamide, and vincristine. This is the combination. You should know that combination, which is used in multi-agent chemotherapy. Treatment is continued in all cases until the beta HCG has returned to normal. So what is the duration of treatment? Until the beta HCG has returned to normal, and then for a further 6 consecutive weeks. So Dr. Thiel, can you hear me? Hello, Athil. Just wondering if everyone can hear me or not. Dr. Daraksha, can you hear me? Now, Dr. Athil, can you hear me now? Can you hear me? Oh, Dr. Daraksha cannot see or hear. Yeah, I stopped my video, but the screen, you should be able to see the screen, Dr. Daraksha. Are you able to see my screen? Okay. Anyway, the session is being recorded. And anyone who cannot attend will listen. No problem at all. I can see that Dr. Mustafa raised his hand, and you want to say anything, Dr. Omnia, Dr. Raksha, Dr. Shazia? Any question up to that level? Okay, no problem. Let us continue. Okay, this is the combination of multi-agent chemotherapy. So how much we will continue? So once the beta HCG return to normal, and another 6 weeks. It's not 6 months, it's 6 weeks. You have to differentiate. After you do evacuation of molar pregnancy, for how many months the thing is 56 days. If it is returned to normal within 56 days, 6 months from evacuation, the cutoff is 6 months over there. But after chemotherapy, once the beta CG returned to normal, it is 6 weeks, not 6 months. The cure rate for women with a score 6 or less than 6 is almost 100%. The cure rate is very good. For a woman with a score of 7 or more than 7 is 95%. Placental-side trophoblastic tumor is now recognized as variant of gestational trophoblastic neoplasia. It may be treated with surgery because it is less sensitive to chemotherapy. So we have placental-side trophoblastic tumor. We will read about it. And I think they asked this question that how to treat it. The treatment is basically surgical treatment because it is less sensitive to chemotherapy. So when can women whose last pregnancy was a complete or partial molar pregnancy try to conceive in the future? Oh, did I mute you? 1 second. Let's see. Dr. Athil, can you talk or still you are muted?
Yes, yes, doctor. No,
You can.
no, I can't talk.
What happened? I didn't mute
Doctor,
anyone.
no, doctor, you mute me.
Oh, I'm so sorry. I don't know how. Okay, so I want you to stay unmuted all the time.
Okay, doctor. Doctor, I want to ask about the incidence of the mole to progress to invasive.
Hmm.
It is from the
Isn't it?
previous page.
Yeah, but you see, I'll show you something.
This is not in the guideline. It is maybe from strategy.
This one is from strategy, but this is guideline.
Yes. This is guideline, but the previous page from strategy about invasive, about the mole, the incidence to progress to invasive mole.
What I
This
believe,
is a treatment.
if you look at
Treatment.
it here, are you talking about this one, right?
No, no,
This,
doctor. The previous page. Yes,
yeah.
this one. Yes, treatment of persistent trophoblastic disease
Mm-hmm. Yeah.
from the top. Yes, this
Oh,
person.
this statement. Invasive moles
Yes,
invade myometrium, but this is in the incidence of invasive. Invasive mole invades myometrium. Now, 10% of hydatiform mole progress to invasion. They're talking about invasion, invasive disease.
yes.
And
This is not
15% of,
present in the guideline.
yeah, it is not in the guideline
No,
because,
no, I
I
don't
mix
remember.
strategy with the guidelines. So maybe because if I find some information important there, I just uh, add this one. So it means might be it is from the strategy. So what is the percentage of invasive mole invading myometrium? Now, 10% of hydatiform mole progress to invasion, 10%, and 15% of invaded the mole which becomes invasive, it goes to lungs or vagina.
Mm.
So not all of them. By the way, what is the meaning of invasive disease? Does it mean that it invade to myometrium or does it mean that it can metastasize?
Means it is metastasized because it invades the venous canals, so it will
Yeah,
be
that's
metastasized.
true. So it means what is the percentage of that hydatiform mole that becomes invasive, right? Either it goes to vagina, it goes to lungs, it goes to brain, it goes to myometrium. So it is 10%. And you are saying that this percentage is not given in the guideline. So maybe it
Yes,
is from strategy, yeah. So what is the percentage? It's going to become invasive, it is 10%. And out of this invasive, how much it goes to lungs or vagina? It is 15%.
Yes.
Okay, but I think the second, this one is also, this is from guideline, right?
No, also this investigation not from the guideline. No.
This is from the guideline. Okay, the I know now. The one in the question answer form is from the guideline, and the one only the something like this is from strategy. Yeah, yeah.
Yes.
This, you
This
are right. This is
investigation, yes,
mm,
this not present in the guide.
yes. Okay. Yeah, and because I find this interesting, that's why I took it from there. Just imagine this one: women with an initial pre-treatment beta hCG of more than 1,000 may stay as inpatient because there is higher risk of bleeding. If in the EMQ they ask about which patient need inpatient and which patient strictly need to be inpatient, then you can say that if the beta hCG is really more than 1,000, then it means that there is high risk of bleeding and she should stay strictly in the I mean, and
Yes.
other patients, you can give them some option if it is less than 1,000. So this is the cutoff given in the strategy. Okay.
Mm.
Women with gestational trophoblastic neoplasia may be treated. This is from the guideline. This percentage is given in the
Yes.
guideline, I think. This is the need for
Yes.
chemotherapy for partial mole. Following a complete mole is 15% and 0.5% need of chemotherapy after a partial mole. 15 and 0.5. Low risk and high risk. We all also covered this one. Okay. Women should be advised not to conceive. So what is for how long you will advise them not to conceive? This is a general question. If you are sitting in your clinic, patient comes to you, she has a molar pregnancy, partial molar pregnancy. It returned to beta hCG returned to normal in 3 months. Again, it after 6 months, you are repeating her beta hCG. How frequently you will repeat, Dr. Atin?
Repeated every 4 weeks.
Every 4
During
weeks
the
you will repeat?
follow-up, Doctor, do you mean during the follow-up of beta hCG?
Follow up. Yeah. I
Yes.
realize
Yes.
that it is not given in the guideline.
No, not is written.
Mhm. So, Dr. Daraksha, is she there? Dr. Mustafa, how you follow up your molar pregnancy? How frequently?
Doctor, I
Yeah.
think you mute all the doctors.
Again, it is automatic. I mean, they are not able to answer.
Yes, yes.
So how you are unmuted and everyone else is muted? Let me see. Okay. I think let me open Dr. Mustafa mic. Okay. It is self-muted. Yeah.
Yes,
Dr. Mustafa,
yes,
how are
Salam
you?
alaikum. Fine,
Walaikum
thank you.
assalam. I want to ask you, you mute yourself or did I mute you? Because Dr. Atil is blaming me that I muted you. Now, yeah, you have to tell me.
I heard you very good, very clear, but I can't talk. You mute me, I think.
Oh, so Athil, you are right.
Yes, doctor.
You are absolutely right. But you see, can you see my screen? I'm saying attendees will have full audio control and may unmute themselves at any time. I say yes. It means everyone can be able to unmute themselves. This is my first, you know that this is the new technology in which I'm I'm using. Now, Athil, unmute yourself and see what happened. Can you still can you still talk? Yeah,
Yes, yes, doctor.
you can talk. Yeah, so
Doctor,
just
we cannot unmute ourselves, only by you.
I have to search, although I'm saying yes, but there is something that I don't, I think no. I'll find out later on. Okay, let me find out later on how, although I'm saying yes, unmute all, but still, do I need to unmute everyone one by one? It's very difficult. It is automatically muting participants.
No, doctor, we cannot
Okay.
unmute ourselves.
Yeah, I need to find out how can maybe the system is built in which everyone will be muted automatically. But I need to see that, do I need to unmute one by one? I mean, this is very difficult. Okay, let's continue, no problem. So now, Dr. Athil, I want to ask you one thing.
Yes.
Women who undergo chemotherapy are, so you have done evacuation. Let us continue from that point. So we have done evacuation. We have done evacuation. Now, when you will say that you can go and conceive?
After doing evacuation, we should follow up by beta HCG. If the beta HCG returns to normal, so she can.
Mm-hmm.
If the beta HCG returns to normal, so she. If she do not use the chemotherapy, she can conceive after the beta HCG returns to normal.
But we just read that we need to continue follow up this patient 6 months
Yes.
post evacuation.
Yes.
So for
Yes.
this six
Yes.
months, we cannot advise her to conceive, right?
Yes. Yes, doctor.
And what about after completion of chemotherapy? For how long you can say that, okay, now you finish your chemotherapy and your follow-up is also complete. Follow-up means for how long after chemotherapy you are following her up? Usually you are follow up every week. So
Every
when
week.
you
Yes.
follow her, yeah, this is what practically what we were doing in my practice, although it is not written in the guideline, but it's every week. If there is something else I find out, we will post in the group, but I think it's every week. So you finish chemotherapy and you are following her up with the beta HCG, and beta HCG returns to normal. You again follow her up. For how long you will follow her up? First, this is my first question.
After chemotherapy, doctor?
Yes.
Um,
So, you know, concentrate on this one. Okay. You can see the sentence that I highlighted, right?
yes.
So, chemotherapy is continued in all cases until the beta HCG level has returned to normal. So, when you are continuing chemotherapy, you are doing every week beta HCG, and then you continue until the HCG return to normal. Then, are you going to stop the chemotherapy when the beta HCG comes to normal? The answer here is no. You will,
Yes.
even if it becomes normal, then treatment you will continue for another 6 weeks.
Yes.
So it becomes normal. You are giving chemotherapy, beta HCG, you are doing follow up, and it becomes normal. Beta HCG becomes normal. But treatment is continued for another 6 weeks, even after it becomes normal. This is very important statement, you know. Okay. As a safe side, what you are doing as a safe side, you continue treatment even if it becomes normal. Okay. So what is their advice? Now, once 6 weeks has passed, you stop now the chemotherapy. Now you stop chemotherapy after 6 weeks from beta HCG being normalized. After 6 weeks, you continue and then you stop. And then from that time until another 1 year, you will tell her not to conceive. This sentence,
Yes.
the last one. Not to conceive for 1 year after completion of treatment. So, you know, in EMQs, they're asking these points. When you, this is a very practical question, the patient will ask you that when she can become pregnant. And they are asking also about the what advice you will give her for contraception. So what do you think? What you will tell her for contraception?
Advise her to use a barrier contraceptive. Because we cannot use intrauterine device. There may be a risk of perforation, uterine perforation. Intrauterine device should not be used until SCG returns to normal. Right, doctor? Hello, doctor?
Yeah, hello. Dr. Athil, can you hear me now?
Yes, yes, doctor.
Sorry if my connection was lost for a few seconds.
Yes, doctor.
So what I was asking you something, right? What was it?
Yes, doctor.
The follow-up OCPs. Can you give OCPs? So can you give her OCPs, oral contraceptive pills?
After chemotherapy, we advise her not to use contraceptive pill until 1 year after stopping chemotherapy.
Yeah. So why not?
Yes, because there is an a low increased risk of developing gestational neoplasia.
That is true. And
Yes.
even this is not only after, whenever you ask after suction evacuation of a molar pregnancy, you are advising women not to become pregnant for 6 months after it becomes to normal, right? After beta HCG becomes to normal. And so after that, what you will give her, I mean, you have to tell her some contraception. So the barrier method is the best, but I have a question. If the patient is, and you are not giving, you are not advising oral contraceptive pills because it will, this statement is about after suction evacuation of molar pregnancy, you are following the patient with beta HCG, it normalizes, it becomes normal. You are telling her not to become pregnant, so you have to advise her some contraception. You are not giving oral contraceptive pill because it will cause the disease to become invasive. Okay. So if the patient, I have a question. If a patient is already on oral contraceptive pills from before, and she used to take oral contraceptive pill and she want to continue oral contraceptive pill, maybe she already started it by herself or something. So what should you do? Should you ask her to stop oral contraceptive pills and come to the barrier method?
No, doctor, we tell her that we advise her that she can continue using the pill, but there is a low risk of developing gestational neoplasia.
Yes. So your answer is from the options. You have option. You will tell her to stop oral contraceptive pill, or you will advise her to continue oral contraceptive pill, and you will tell her to start using barrier method, or you will tell her start using you will give her IUCD. There are many options, for example, of this EMQ. So your answer should be that you will not tell her to stop, and you can give her advice to continue using oral contraceptive pills if she already started using it. But you will tell her, as you said, if the option says that you will counsel her, if the option does not say, but your answer should be that no, she can continue OCP if she already started it. This should be the answer. And I saw it from the recall. So because these EMQs are coming to my mind, how they are coming to my mind while I'm reading this guideline, because I'm doing recalls, and I know that this is what they're asking from molar pregnancy. I know already because I'm doing recalls. This is the advantage of doing recalls. You, while you are reading a topic, you will know what are the questions the RCOG is interested in, and you can create your own EMQs if you have an idea how the RCOG is I mean creating EMQs. You can create your own EMQs also. That is why there is an advantage. So all women who have their beta HCG checked twice a week, and so how you will know? You are checking once in a week after doing suction evacuation, but you, once the patient is in chemotherapy, you will check twice a week. This is how you know that, how you check the frequency. It is written in the guideline, but we are not concentrating. This is the problem. I think we missed the first paragraph, right? The low risk methotrexate is usually well tolerated. The most common side effects are um, pleural inflammation, mucositis. These are the side effects of methotrexate, and you should know it. Hepatic toxicity, but rare. these side effects are rare, but this is the side effects. So pleuritis, mucositis, hepatic toxicity. If low risk women with lung metastasis, we add central nervous system prophylaxis with intrathecal methotrexate. Okay. So there can be intrathecal methotrexate also, which is administered on 3 occasions, 2 weeks apart. Anyway, so now this, I think this statement is important. That's why I highlighted it. While the patient is on chemotherapy, you should check her twice a week. And following SCG norm, once the beta SCG become normalized, chemotherapy is continued for another 3 cycles, which is given in previous slide also, 6 weeks, to ensure eradication of any residual disease present below the level of SCG detection. Overall, 2/3 of the low risk will complete treatment with methotrexate. However, for those who have an inadequate response to methotrexate, and if the beta SCG is plateauing or rising, treatment is changed to second line chemotherapy. That is why they are checking the beta SCG, because she might need a second line chemotherapy for this single agent. And if you are giving her a second line chemotherapy, then you should use because they might ask you a question in EMQ that you are giving a chemotherapy to a patient, that you are giving a chemotherapy to the patient. That you are giving a chemotherapy to a patient and she is not responding. She is not responding, right? So, and she is not responding, then you have to give the second line chemotherapy. And what is the second line chemotherapy? Okay, let's see. I think we missed that part before. Okay, 6 weeks. We read this one. 2/3 of the low risk group will successfully complete treatment with methotrexate. Again, however, for those who have inadequate response and beta SCG is rising or plateauing, treatment is changed to second line chemotherapy. And we should remember this one. What is the second line chemotherapy? Dactinomycin is given intravenously at 0.5 milligram on days 1 to 5 every 2 weeks. If the beta SCG is under 300, it is better to remember. Or a combination chemotherapy is used if the beta SCG is greater than 300. Although we are not concentrating on this, but they can ask this question. Okay, there is a combination called IMECO. It's a combination of etoposide, methotrexate, dactinomycin, cyclophosphamide, vincristine. It gives an intense treatment with the 5 chemotherapy agents delivered as 2 groups 1 week apart. The combination treatment has considerable side effects, including bone marrow suppression and support. So you have to support it with the granulocyte injections. Fortunately, other serious toxicity is rare with IMECO, and the majority of women tolerate treatment. Similarly to the low-risk women, chemotherapy treatment is continued for 6 weeks after the normalization of SCG level. So this is for high-risk women. IMECO you are giving for high-risk women, and chemotherapy is the same like low-risk, You continue for 6 weeks after normalization of beta-HCG, and you have to check the beta-HCG twice per week. Now, what is the outcome of treatment? Risk of relapse is 2% for low risk disease and only 3% for high risk women treated with EMECO. This is the risk of relapse. You should remember this figure. What is the risk of recurrence? For low risk, 2%. What is the risk of recurrence for high risk is 3%. If they occur, recurrences usually happen when the recurrence happened, within 12 months or within a year. That is why we are asking the patient to avoid pregnancy for 1 year. During that time, in this case, the beta-HCG from the new pregnancy masks the HCG production. This is the logic. They're giving this as a logic. Why you are asking the patient not to become pregnant after chemotherapy for 1 year? Because of this reason. Subsequently, fertility after chemotherapy is maintained and menstruation can resume within 6 months of chemotherapy. And but menopause can occur 1 year earlier in low risk and 5 years earlier in high risk chemotherapy groups. Okay, this is from the strategy. I find it interesting. Persistent gestational trophoblastic disease or gestational trophoblastic neoplasia most commonly presents as irregular bleeding following evacuation of a hydatiform mole. Malignant changes arises after 15% and 0.5%. It is given in the guideline. No need to panic. Risk factors for developing persistent gestational trophoblastic disease or neoplasia. This is important. So what is the risk factor? That this patient can become neoplasia if the beta-HCG is more than 100,000, if the uterine growth or size is more than 20 weeks, or they are theca lutein cyst more than 6 centimeter in diameter. You will not find it in any guideline or talk article. If you find a big theca lutein cyst which is more than 6 centimeter diameter, it means most probably this will turn into gestational trophoblastic neoplasia. Because you know, Dr. Atil, that theca lutein cysts are directly related to the beta-HCG.
Yes, yes, doctor.
And what is the percentage of finding, for example, there is a scenario in which you have bilateral theca lutein cyst. What it can be? In your differential diagnosis, what it can be? Bilateral theca lutein cyst. Now you have different options. Twin pregnancy, heterotropic pregnancy, molar pregnancy. What you will choose?
Molar pregnancy.
And what about heterotropic pregnancy? Bilateral theca lutein cysts are present in heterotropic or not?
Yes. Yes, yes, maybe.
So what should be your answer? Is it heterotropic, your answer, or your answer is molar? I want to see if you can write in chat. Write something in chat. Did you write anything?
No, doctor.
Can you find the chat section?
No.
You cannot find the chat? I sent to everyone hi. Can you see that? You cannot?
No, doctor.
Oh, it's not good. Mhm. Okay. So, but I think you can raise your hand, right? Only.
Yes, doctor. Yes.
So, I want someone to raise hand so that I can open the mic. So, the bilateral corpus luteum cyst, if there is an option of molar pregnancy, heterotropic pregnancy, twin pregnancy, what you will answer? I don't see any raised hand. Okay. The only raised hand, I don't know if other people can raise their hands or not. Okay, so what you will answer, Dr. Atil?
Doctor, I think molar pregnancy is more common to see bilateral luteal cyst.
Yes, your answer should be molar, because the percentage of heterotropic pregnancy, in heterotropic also you can see bilateral also.
Mm.
But the percentage overall of molar is more than heterotropic. That is why your answer should be molar.
Yes.
Okay.
Yes, doctor.
And then you see, sometimes you just need to use your logic and common sense. Not everything is written in the guideline, you know. And sometimes they're asking questions which only needed common sense only. Okay, so if the age is more than
Doctor,
40,
one of the presentation of molar pregnancy to present with abdominal distension due to bilateral luteal cyst. In
yeah,
the guideline,
cyst can
yes,
be very big. Can you imagine this cyst? It is more than 6 centimeter in diameter. So the cyst can be very big. 6 centimeter is a big cyst, more than 6 centimeter.
yes,
And it can be multiple cysts also, which can even cause ovarian torsion. And cyst can rupture also, ovarian accidents can happen. Okay, if age is more than 40, repeat molar pregnancy, and aneuploid mole, medical complications of molar pregnancy, like if she developed preeclampsia and hyperthyroidism, it means it has more risk for developing persistent gestational trophoblastic disease. Any evidence of distant trophoblastic embolization, it means high risk for gestational trophoblastic neoplasia. Okay, what are the signs suggestive of post-molar gestational if you evacuate the molar pregnancy? And as you said, still she has enlarged and irregular uterus, ovaries are enlarged, elevated beta HCG, then and some of the criteria which we already discussed after evacuation, that it means that this is a neoplasia and she will need chemotherapy. FIGO scoring system. FIGO scoring. This FIGO scoring is there in the guideline, right?
yes,
So if the age is, so it just, you know, you just skim and just look at it. Once you will solve your EMQs or questions, then you come back to it. So I just want to have a look, just look at it, that figure scoring. And you know what is the low risk? 6 or less than 6 is low risk, and 7 or more than 7 is high risk.
yes.
And you are going to calculate these numbers on the basis of these scores which is given here, and it depends upon the age, the antecedent pregnancy which was mole or abortion, and the interval from this pregnancy to the treatment, and the pre-treatment beta HCG level, you know, and the size, tumor size of the tumor, including the uterus in centimeter, largest tumor size, site of metastasis, where it is, because as you can see that once the score is increasing, if it goes to liver and brain, it means higher score, and it depends upon number of metastasis also. So if you have more number of metastasis, most higher risk, and if it failed chemotherapy before, single drug failed is 2 risk, 2 or more drugs failed is more higher risk. Okay, and the stages, I think this is from strategy. So stage 1 means gestational trophoblastic neoplasia confined to the uterus. Stage 2 is gestational trophoblastic neoplasia extends outside of the uterus but is limited to the genital structures. And stage 3 extends to the lungs with or without known genital tract involvement. Stage 4 is gestational trophoblastic neoplasia extends to all other metastatic sites including liver, kidney, spleen and brain. These are 4 stages that are given in the strategy. Okay, just imagine the symptoms indicating gestational trophoblastic neoplasia. If it goes to the lungs, it may cause dyspnea, cough and chest pain. If it goes to the GIT, might cause abdominal pain, hemoptysis, melena. If it goes to the brain, it might cause intracranial pressure, intracerebral hemorrhage, headache, seizures. So all these are symptoms. They might give you EMQ in which they will tell you the symptoms only, and then you have to assume that it is spread to the brain. That's why it's causing seizures. That's why it's causing headache. That's why there's intracranial pressure and sign and symptoms of intracranial pressure. You know that, blood vision and all these things. The need for chemotherapy treatment in gestational trophoblastic disease is identified by evidence of persistent gestational trophoblastic disease. So the need for chemotherapy is identified by evidence of persistent gestational trophoblastic disease that is unlikely to resolve spontaneously or histopathological diagnosis of gestational trophoblastic neoplasia. Okay, once identified, this is all is given in the guide. The only thing which I want to show you the symptoms, indication for chemotherapy, which already we discussed about it. What are the indications for chemotherapy? Okay. And we already said that if the chest x-ray is more than 2 centimeter, we already discussed. If the beta HCG after 4 weeks more than 20, we already discussed. And if the beta HCG is plateaued, it is written there 3 or more. It is written here 4 or more. As rising as 2 consecutive increases in beta HCG of 10%, it is elaborated more here actually. So they are saying and rising as 2 consecutive increases in beta HCG concentration of 10% or more for at least 2 weeks. You know, they explain more what is the meaning of plateaued beta HCG. It is defined as 4 or more equivalent values, or before we read 3 or more. Anyway, whatever is it, it is equivalent values of beta HCG for at least 3 weeks, and you are checking it every week, right? This is every week, 4 times, and rising, or if it is even rising as 2 consecutive increases in beta HCG of 10% or more for at least 2 weeks. You are checking at day 1, which is I think day 0, the time when you are checking, then next week, and then after that again next week 2 more. If it is increase in 10% or more for at least 2 weeks. I think that they are defining what's the meaning of plateaued beta HCG.
4 or more.
Yeah, here in strategy they said 4 or more. Patients who fulfill the chemotherapy treatment criteria, a comprehensive, what you have to do, they require before you start chemotherapy, clinical assessment, and the investigation I already told you, CNS assessment, which should be performed and may necessitate further such as MRI brain if indicated. A baseline SCG, you see the investigation, what is written here?
Yes.
Before chemotherapy. Baseline SCG, thyroid function test, urine electrolytes, liver function test, you will not find it in the guideline. And a full blood count, chest X-ray, pelvic and abdominal ultrasound to confirm absence of pregnancy, measure uterine size and volume, spread of disease. Because in the guideline they said Doppler, but they did not clarify why they want Doppler. They want Doppler because they confirm the absence of pregnancy, because they want to check the disease in the vessels or not. Disease vascularity can be used in the prognostic manner, as high vascularity correlates to patients who are at risk of monotherapy resistance. That's why they want Doppler. A review of all relevant molar or gastro, you should have reviewed all the histopathology. This is pre-starting, before starting this one, the chemotherapy. Okay. Now, although a CT scan, now this is important information. Although a CT scan of the chest has better diagnostic accuracy than a chest X-ray is the preferred initial investigation. Why, Dr. Atil? Because it is cost effective. The presence of and less radiation to the patient. The presence of pulmonary micrometastasis can be seen on the CT chest images in approximately 40% of cases. The presence of pulmonary micrometastasis can be seen on the chest images in 40% of the cases, but are not detectable on chest X-ray examination. But what is the cutoff of significant metastasis in the lungs, Dr. Atil?
More than 2 centimeters.
Yes, we are not concentrating on a small metastasis. So why should we do CT? However, if macrometastasis, pulmonary lesions are noted, but if you note a macrometastasis, which means more than 2 centimeter, then you have to do MRI of brain and body CT would be recommended, because there is an increased risk of more widespread disease, which would impact on staging, prognosis, and treatment decision making. It is not written anywhere, not in TOG article and not in guideline.
Yes. So, doctor, we should read strategy in molar pregnancy.
Yes, I will tell you something. Because I read all strategy now, but before my exam, it is, impossible to read all strategy, practically speaking, to tell you the truth. But there are few topics in which you should read strategy, and while I'm doing the course, I'm bringing I just copy paste from the important topics which needs to be read, because I read all because I'm teaching. But before the exam, to tell you the truth, I had no time to read all the guidelines, all the TOG articles, Faculty of Sexual and Reproductive Health, blah blah blah, plus strategy. No, I just read few topics which someone will tell me you should read it from there, maybe 2 or 3 topics from there. But for me, I was not, because I was working, I have family, and there is a lot of material. I'm telling you because I read all, so that I can tell you, okay, this is important, and they might ask you this one. Similarly, MRI of the brain and body CT would also be indicated for prognostic high risk patients, as defined by the FIGO scoring table. So this is another indication of doing in high risk patients also MRI brain and body CT. And pre-treatment, if the pre-treatment BTSCG is more than 50,000, it's very high, more than 50,000 also. So there are, actually you can say, these are the recommendations of doing MRI brain and body CT, and it is given in the strategy. Okay, this is how the choriocarcinoma looks like, and the histopathology. Choriocarcinoma may complicate 1 in 50,000 pregnancies, very rare, right? And 1 in 43% of Hydatidiform. How many Hydatidiform moles can be converted into choriocarcinoma? 3%. Tumor metastasis to distinct site occur by vascular. How it spreads? Vascular. 1/3 of cases with choriocarcinoma present with it is also possible that maybe choriocarcinoma can present with non-gynecological features. Excision biopsy of a metastasis should be considered to confirm. So how you will know that if there is a metastasis because of choriocarcinoma and this is choriocarcinoma? By excision biopsy of a metastasis. FIGO 2010 scoring system and treatment is the same as, so the scoring is the same and the treatment for choriocarcinoma, what is the treatment? Chemotherapy. The scoring according to the score. So you will score it and then you will give her chemotherapy. If only maternal genes are present, then the metastasis is a non. How you will know that this is ovarian choriocarcinoma? Why I bring this special one sentence? Why I copy and paste it? Because they're asking in the questions in the exam. Because there is ovarian choriocarcinoma. You know that, Dr. Athil, right?
Yes.
That there is an ovarian choriocarcinoma and there is uterine choriocarcinoma. Or sorry, gestational choriocarcinoma. There are two kinds of choriocarcinoma. And if there is a metastasis only, then how you will know that this metastasis is from ovarian or this metastasis is from gestational? So if only maternal genes are present, it means it's non-gestational. Only maternal genes are present. But in gestational, it is both, right?
Yes.
This is how you can differentiate. Non-gestational, like ovarian choriocarcinoma. Because it is from the mother only. It's not gestational. Placental site trophoblastic disease. So what is, I find they are asking about placental site trophoblastic disease, you know. Now placental site trophoblastic disease, now we have like 10 minutes more. I know I extend more than 2 hours and I said only 2 hours, but just we will do 10 minutes more. So placental site trophoblastic tumor is an uncommon but important variant. Okay. So how is it? It consists of mononuclear intermediate trophoblast syncytial elements without chronic villi. This is the histopathological differentiation, that it will have trophoblastic tissue. It can be mononuclear, intermediate trophoblast and syncytial trophoblast, but there will be no chronic villi. Infiltrating in sheets between the myocytes. So it will be infiltrating between myometrial fibers. Placental site trophoblastic tumors are often diploid. And the other important thing are they are diploid. Mostly they are diploid than aneuploid. Most arise following non-molar pregnancies. This is another important information. These tumors produce only a small amount of SCG. What is their tumor marker? Is their tumor marker SCG? No. Their tumor marker is human placental lactogen and tend to retain confined to the uterus. They metastasize late in their course. The disorder should be suspected if beta HCG are low for the volume of disease. So you will see a big tumor inside the uterus but beta HCG is not that high. Histological analysis is needed to confirm the diagnosis. So you will send it for the histopathology and that will confirm the diagnosis. Compared to choriocarcinoma, and you will have the tumor marker also. Compared to choriocarcinoma, this is associated with less vascular invasion, so less spread, right? Vascular spread is less. And necrosis and greater tendency for lymphatic spread. So it can spread more through lymphatic. But choriocarcinoma spread to vessels, to blood. Patients with metastatic disease need combination multi-drug chemotherapy. However, they are insensitive to chemotherapy. This is another difference. And hysterectomy and pelvic lymphadenectomy, why they are telling you that it is spreads to the lymphatic spread? Because they want to tell you later on that you need for it not only hysterectomy, surgical treatment, because they are insensitive to chemotherapy, they need surgical. In surgery, you have to do not only hysterectomy, but pelvic lymphadenectomy because it goes to the lymph nodes. Advice on the management should always be sought from the, of course, registration center. You will consult registration center in all molar pregnancy. Since beta HCG is not a reliable marker, long-term clinical follow-up is recommended because you cannot just follow up with the criteria given for the molar pregnancy or choriocarcinoma. What is the long-term outcome? Now, women who receive chemotherapy are likely to have earlier menopause. We already said 1 year for low risk and 5 year earlier for multiple chemotherapy or high risk. Women with high risk require multiple, should be advised because of the etoposide that they are giving in multiple high risk chemotherapy. Should be advised that they are not only this, but they are even at the increased risk of developing secondary cancers. I think the cyclophosphamide also causes early menopause and amenorrhea in some cases also because it affects on the ovarian tissue. So what is safe contraception following diagnosis of gestational trophoblastic disease and when should it be commenced? Women should be advised to use barrier method as we already discussed. Once beta HCG is normal, OCP may be used. There is no evidence to whether single agent progesterone have any effect on gestation. So Dr. Thiel, can you give mini pills? Okay, OCPs should not be used. What about the Cerazette or mini pill? Can you give? What happened? It again muted.
Yes, yes, doctor.
It again muted, right?
Yes, yes, doctor.
So it means it automatically, this is not good. It means
No,
immediately.
it is written that the organizer unmute you.
Yeah.
Mute you
No,
and
I have
unmute you.
to unmute each and everyone. It should be when I say unmute all, it should unmute all.
Yes.
Okay, no problem. So what was the question? I even forget.
About the pill,
Yeah,
contraception pill.
the
Yes.
mini pill. Can we give the patient mini pill?
The same for combined pill. After normalization of HCG, we can give it.
Okay. If oral contraception has been started before, now this was the question in the EMQ. If oral contraception has been started before the diagnosis was made, the woman can be advised to remain on oral contraception. But she should be advised that there is a potential but low increased risk of developing neoplasia or invasive disease. Intrauterine contraceptive devices should not be used until beta HCG levels are normal to reduce the risk of uterine perforation. This is given in this exactly what they gave in the EMQ. Is hormonal replacement therapy or
Doctor,
HRT?
Doctor, about this pill and the IUD, this is after molar pregnancy,
You know,
not for
this is
after chemotherapy. The same can be applied.
to tell you the truth, the headline says following diagnosis of gestational trophoblastic disease.
Disease, not neoplasia.
No, this is after you did evacuation. You have gestational trophoblastic disease, molar pregnancy, partial mole, complete mole. You did evacuation, and
We
then you
can use the
advise her.
contraceptive pill and the IUD after the HCG returns to normal
Returns to
only.
normal. Yes, this is what but they are saying here, I want you to concentrate on this line. There is no evidence as to whether single agent progestogens have any effect on, it means, is it increasing the incidence of neoplasia, the single agent progesterone like mini pills or Cerazette? They are saying there is no evidence.
Yes.
So it means that shall we give or not? Although about the combined oral contraceptive pill, they are saying that you can give it once the beta HCG becomes normal, right?
Yes.
But for this, they are not very clear. So I'm wondering, shall we give progestogens or not? Because from this sentence, there is no evidence as to whether single agent have any effect on gestational trophoblastic neoplasia. So there is
Yes.
no evidence that is it affecting, is it causing the disease to become into neoplasia. The
Yes.
only thing that they are considering here is combined oral contraceptive pill. That should be used after PTSCG becomes normalized. Okay, but here they said women can be advised to remain on if she started already before the diagnosis of molar pregnancy, she can continue on it, but you have to inform her. Okay, HRT, the same thing. Once it returned to normal, then she can continue HRT. NTD, women who are rhesus negative should receive NTD at time of surgical evacuation, as NTD is expressed on trophoblast. Okay, hysterectomy. Should we do hysterectomy? Hysterectomy may be considered as an elective or emergency procedure. Although hysterectomy eliminates the risk of uterine source, but it will not eliminate extrauterine trophoblastic source or the potential need for chemotherapy. SCG surveillance should still be continued post hysterectomy. If they might ask you, if you have done hysterectomy, she completed her family, she developed molar pregnancy, complete molar, and she do not want any risk for having invasive disease, gestational trophoblastic neoplasia. So she wants hysterectomy for other reasons also, but she wants hysterectomy. So should you stop her SCG surveillance? The answer is no. You should continue the surveillance post hysterectomy. And this is I took from the strategy. There is difference between complete and partial. We already discussed about it, about diploid and triploid. It can be 69XXX and it can be 69XYY and it can be 69XXY. Because I don't know, I don't remember exactly, but they ask three combinations. What three combinations are possible in some of the questions? Anyway, it is written in a strategy that these are the combinations possible. Okay.
Yes, because there are two sperms, so it may be 2X,
Yeah.
2Y, or XY.
Yes. Because Y might come from the sperm or X might come from the sperm sometimes. And this one, 10% can be tetraploid also or mosaics. Not only triploid, they can be tetraploid. Okay, and 90% are from one sperm. And they're talking about this one, complete. And 10% can be dispermic, as we already saw from the diagram for the complete mode. One sperm can come, and if one sperm comes, you see, very nice. If it is monospermic, because they are fertilizing an empty ovum, right? So if it is monospermic, what you will get 46XX. And if it is dispermic, it can be 46XX and 46XY.
Yes.
And in partial mole, 90% will be triploid. This can be the combination. In 10%, it can be tetraploid, and they did not give what is it. It's only 10%. But you see, I don't remember exactly, but they're asking these combinations. So maybe it's important to remember. So what is the prevalence? 1 in 1,000 complete, and it is 3 per 1,000. Fetal tissue and red cells are absent in complete, and it is present in partial. And the histopathology, this is complete and this is partial. You see, histopathology is important also. Diffuse villous hydropes, trophoblastic hyperplasia, cystic villi have appearance of grapes-like structure. Here in partial focus villous hydropes, scattered abnormality, focal hydropic hyperplasia, everything is focal. Trophoblastic pseudo-inclusions, and it can be identified fetal tissue. Now this one, you see, immunohistochemistry. What is the difference? Although in the guideline they just mentioned P57, but they did not explain it. In complete, P57 is not expressed. In partial, P57 is expressed by maternal allele on cytotrophoblast and villus mesenchyme. They are explaining it in a strategy, that what is the difference, how you differentiate, but they are saying in the guideline you differentiate it between partial and complete with the help of P57. But how you will differentiate? This is complete and this is partial, right? If P57 is not expressed, incomplete P57 is not expressed, this is how you will know that this is complete. But in partial, P57 is expressed. And they can ask you in exam this question, how from the immunohistochemistry you will know. This is histopathology, but this is immunohistochemistry, P57. And this is FISH technique, in which you will know the ploidy status. All these things are important to diagnose in not only histopathology. In FISH, you will see the DNA ploidy. Here in complete, it is diploid. You know that. In partial, it is triploid. And in complete, what is the risk of requiring chemotherapy? Because she might have persistent gestational trophoblastic neoplasia. It is 15%. This was your question, right, Athil? What is the percentage of gestational trophoblastic disease
Yes.
converting into gestational trophoblastic neoplasia? And in the guideline, it is written this is the percentage which requires chemotherapy. Isn't it the same? That the people who require chemotherapy are the people who are converting into gestational trophoblastic neoplasia or persistent.
No, doctor. About the partial mole, the incidence to be invasive. This percentage is present in the guideline.
Yeah. So what was your question?
About what percentage that the partial mole will become invasive.
Hmm.
And it is the 10%, and 15% of the invasive mole will go to the lung and vagina.
Yes, and it is, oh yes, this was your question. It is not written in the guideline.
Not written in the guideline. Yes, doctor.
Okay, no problem. You know, very nice table I find in complete mole and in partial mole. For example, but we already know this one. What kind of karyotypes you will see. Just remember this from the strategy. We will not go to this one. Beta SCG. Here if they are asking you in multiples of median, here you will find it from that very old TOG article. I saw in one, I don't know from which year they are asking multiples of median. So in complete mole, it can be between 10 to 200 multiples of median. In partial mole, it can be from 10 to 60 multiples of median. And you see the percentage, Dr. Thiel, of bilateral multicystic ovaries?
Yes.
Bilateral corpus luteum cyst. In complete is 15 to 25%, and partial is 9%. It can present as hyperemesis gravidarum, preeclampsia, hyperthyroidism, uterine enlargement, anemia. And we know about the postmolar gestational trophoblastic neoplasia. Here the percentage is given here also. If it is a partial molar, 1 to 10% can be transferred and proceed to gestational trophoblastic disease. But if it's a complete, the percentage is higher. I find this from this TOG article. Just I bring like 2 slides from that old talk article because I find this information, especially about multiples of median, that I don't find it anywhere. Okay, so let me stop. So any question? I hope I can unmute everyone. So can anyone raise the, maybe this is the way it works. If someone raised the hand, then I can unmute him, right? Unmute her. So if anyone raised the hand, then I will unmute. And I will check in the recording, in the setting also, how can I unmute everyone? Because this is by default, this setting is by default, that everyone will be muted. No one raised the hand. And you're Dr. Mustafa, so I need to unmute. Are you unmuted, Dr. Mustafa? Can you unmute yourself? 1 second. I think I unmute now. Yes.
Yes, now.
Yes, Dr.
Unmuted.
Mustafa.
Before muted me, now no.
Now I'm asking you that you are doing your sessions with the, have you ever used GoToWebinar? Is it how it
Hello?
works? That is it working like this? You used it before?
No.
So because I'm using GoToMeeting usually, and I don't
Yes,
encounter.
GoToMeeting better than Wember.
Oh,
Best.
yeah. But the problem, the video is not very clear in GoToMeetings. If I want a webinar with a video, the videos are not very clear with the GoToMeetings. Have you tried with video recording?
Record,
Audio is
you did?
audio is okay with GoToMeeting.
Yes, yes, yes.
Yeah, audio is perfect. I am doing it since 3 years, but video is the problem. If I want to record a video, then I think GoToWebinar is, anyway, I'm still in a learning curve. Anything you want to comment or you want to say?
يعني you sure muted me, but very good session, complete information, complete everything about gestational trophoblastic disease. Thank you very much.
I just tried.
And you cover
Because,
everything.
yeah, I tried, but I'm sure that there will be few questions that is still, you know, we might need to go back to it, because sometimes we are not concentrating too much on one point in which the questions are asking, and then we go back. So if we have a presentation which is complete, then whatever the questions will arise, we can go back to it and we can again look at it, because the information will be here. Either it is in the guideline, either it will be in the talk article, it will be in the strategy. I mean, 90% of the information will be there. What do you think? I think 90% or more information you will find it over there.
Yes, yes.
Okay, then I think because it is taking more than 2 hours, and I'm going to stop the recording now.
I want to ask about 20 questions in recall
Yes.
2015. 15.
Yeah. Yes.
Questions number 9. A woman undergo evacuation of delay miscarriage. Histopathology, complete mole. What is the risk developing choriocarcinoma? Answer 140, 1 by 40 or 1 by 80.
Yeah,
This
do you
is
know how to
problematic.
convert percentage into 1 in 40 or 1 in? In complete mole, I think the incidence of converting into choriocarcinoma is 0.5%, right?
Yes.
Yeah. So how you convert 0.5% into 1 in... So 1 in 100 is 1%. And 1 in 50, I think, is 0.5%.
Yes.
So what
Doctor,
are
the
the...
question, the percentage of complete mole to be converted to choriocarcinoma? This is the
Yes.
question?
Yeah,
Yes.
so anything which is close
Yes.
to 1 to 50, we can answer this as right. In the options, is there anything near to 1 in 50?
2-3% written in epidemiology and strategy. In strategy 1 by 40. Recurrence
Yeah.
of molar pregnancy, yes. In 1 in 80.
But I think if you go, even if you go by the guideline, the risk of complete molar converting into choriocarcinoma is
Doctor, it is not written in the guideline.
so from where we find this one? 1 second.
This questions in recall 2015.
Yeah, but we just
But we can't confirm its answer here.
choriocarcinoma and 1 in 40 of hydatidiform moles. Yeah, I think this is in the strategy. You are right.
Yes, in strategy.
Choriocarcinoma, yeah, in a strategy it is there. 1 in 50,000 and 1 in 40. Yes. So is there option like 1 in 40 is there?
120, 140, 1 over 60, 1 over 80, 1%, 1 over 200.
Yeah, so
5
you will
options.
choose 1 in 40
Okay.
because it is there in the strategy. And you see, Mustafa, it is not in the guideline.
No in guideline. No.
Yeah, that is why you need to combine TOG article, strategy, and guideline. You cannot read from one. It's very difficult to pass EMQs by reading only one guideline or TOG article. And what's the other EMQ? We will solve now, no problem.
Doctor, about this question, they specify complete one. Is it the same?
You know, to tell you the truth, just tell me. There is higher incidence. Mostly the complete moles are converting into choriocarcinoma. You know that,
Yes.
Atin. Yeah.
Yes.
So sometimes we need to assume also and use our common sense.
Yes, but it is very difficult question.
Why everyone
even
is
if I read the guideline and the talk, I couldn't answer this question.
Yeah, because it is not in TOG and it is not in guideline, it is in strategy.
Yes.
Okay, so what is the next question, Dr. Mustafa?
For me, not more. Thank you.
Okay, thank you very much. And now this is a challenge. Technology is a big challenge for me. So let me see, how can I stop my recording? Okay. Let me just bear with me. I will just, yeah, I find it. Okay. Stop recording.